Good morning, guys. Those who are sitting here and those who are listening to me at your comfort areas. I wish and pray for your health, well being, and success. So, with this note, I like to start. So far, we were able to cover the major chunk of my MSK block, and we are left with very little. Today, we'll be talking about the leg, and then one last lecture which is regarding the subject, directly with the subject, that will be covering your ankle and foot. And after that, there will be one session of clinical anatomy. There I'll try to bring some important concepts which are connected to our understanding, and those are really important areas. So I'll be re-emphasizing on the structures of upper limb and structures of lower limb, which has more clinical relevance. Obviously, I cannot cover everything, but I'll try my best to cover all, right? Second thing, we had some review sessions which we have conducted in the evenings, and if you're interested, you start preparing your question. Shortly, your BLCs will be throwing a survey and send your questions, so those questions can be organized and we can have a similar type of a long review session where I'll feel obliged to help you to answer your concerns and questions. So now, I have tried to correct things. Sometime, like this lecture on knee joint was having a glitch regarding the sound, so I replaced that. I did a new recording. It is visible there. So please keep checking. Keep checking your things. And then the second thing is this week, which has started today. This is your live, direct last week of covering all your concept. So you all are requested, you all are expected to spend good time in your labs, have good identification, good orientation with the cadaveric material as it is, because the other stuff you'll find in the books, in the pictures and other formats. But the real stuff will not be available, will not be in your access. So this week is the real prime week, and utilize these 2 hours which you are spending in your lab sessions very generously, and you can grab all what is needed. Okay, so I hope you are adults. I need not to say again and again, and we are good to understand. So now, to share my screen. So now, today we'll be learning about the leg. Now, what do you see on this image, which has been shown to you? Just think for a second what it is. So, any concern, any answer, anything which comes to your mind? Guys, what you're looking on the screen? Screen is not showing you anything. I'm sorry for those who are sitting here. I know those of you, okay, fine, now we are good. Gentlemen, do you mind turning off the lights? I'm sorry for asking again to you. So, what do you see on the screen? Leg, yeah, it's written also. So, but this leg, there are 2 images to the leg and they are showing different features. So, what are those features? What about this leg? If I compare with this leg. So, someone is saying gangrene. Fine, you may be right. So, we'll be talking about this concept today. That what are these changes? Where somebody is thinking that this is gangrene. So, let's go over. So, now, just quick revisit on the bones. The bones who are contributing to my leg, and the bones are tibia and fibula. Fibula is placed laterally and tibia is placed medially. And they are connected in the middle by a membrane which is very thick. It's a similar concept which we have used when we were learning the forearm. And this membrane which connects my tibia and fibula that is known as interosseous membrane. It's very strong, and it helps even in kind of weight transmission as well, muscle attachment, everything. So now let's start labeling. We know about these features. I'm not spending time on these are just labels. Nothing new. Dr. Ayman has spent good time on explaining these bony features during structure of the week session. So I need not to go in detail. So whatsoever is visible to you, this is required. Do you understand? This is required. Any ambiguity, any questions so far? Fine. When you don't say anything, it means all is fine. All is well. Now, my usual practice, I like to start with a section. Now this section, as we are talking now the leg, so this will be at the leg. And outermost red core is what? The skin. And then we have superficial fascia, which is always made up of a membranous layer and a fatty layer. And then you're looking at medially, there is a blue thing, blue or white thing. That's one of my superficial vein. That vein, thank you very much. The name of this vein is great or long saphenous vein. It extends from the dorsum of my foot. It runs on the medial side of my leg, medial side of my thigh, and its ultimate destiny is, after piercing deep fascia of my thigh. The name of deep fascia of my thigh is fascia lata. It pierces that, and then it enters into femoral vein. Now, and there is another one which has been shown posteriorly at the bottom. That is small saphenous vein or short saphenous vein. Guys, these saphenous veins, they have their clinical applications. We use them a lot. Especially the great saphenous vein is used as a graft in various needs of the body. When someone has an accident, some vein has been damaged. Even some artery has been damaged. So to replace a tube, so this is the tube which is available. We can replace it, we can connect it, the missing tube. Because you cannot buy a vein, you cannot buy an artery from any store. So you need to depend upon these structures. So this is what we have. And now you may ask me a question, if we take this long saphenous vein or short saphenous vein for the purpose of a conduit, for the purpose of a replacement, what will be the job? Who will take care of the job which has been carried over by this structure? Because whatsoever is being given to us, we need all of those things. So who will take care of that? The long saphenous vein which you have replaced, which you need, and especially the people who are undergoing cardiac bypass surgeries. Long saphenous vein is being used in most of the institutions. There are other options available. I'm not going into cardiac bypass surgery details, but I can tell you most commonly used tube to replace those arteries of my heart which has been blocked. The tube which has been used is the long saphenous vein in major situations. But we have other options as well. Now, after saying this much, this green thing is, this inner ring is my deep fascia. And inside, we know that medially we had a big section of a bone, and that bone we call it as tibia. Can you see that? It is almost covered. It's almost under the deep fascia. So that part of the tibia, which is almost touching this green core, that part is subcutaneous. If you feel your own leg, you can feel that part. There is no muscle covering that part. So this becomes a subcutaneous surface of my tibia bone. It is just under your skin, superficial fascia and deep fascia. We have to be clear about that. And you can see that. And one tiny bone, which is just placed in middle, slightly laterally, that is my fibula bone. So where I'm talking, this is my tibia, and this is what I was explaining here, and this is my fibula. Fibula bone is primarily for muscle attachments, and tibia bone serve the purpose of weight transmission and other things. And this fibula, we use it for various, where we need to replace a bony stuff, where we need a bony chip, where we need a bony replacement. So if we have to use a real natural, there are different type of grafts which we use for reconstructive procedures. So femur bone, part of the femur bone is being used, so we can spare that part. Those details not needed to know now. We'll be talking again after. So now we talk about the subcutaneous border of the tibia. Now what I'm doing, what I've done, can you see that? Towards my fibula, there are two septors which are coming up, and they are creating what? A compartment. And then there is another thing which is connected, which is present between these two bones, and we call this as the interosseous membrane. So now my leg is being divided into one posterior compartment, one anterior compartment, and one, what is that? Lateral compartment. Perfect, you guys are good. So now let's take these compartments. So these are the names of these, the partitions, the intermuscular septums, and then we have the interosseous membrane. We talk about these. So now those who live in the anterior compartment of my leg, their job is what? Dorsiflexions, and they are acting as inverter. Can you close the sound of your doors? So they are doing what? Dorsiflexion and inversion. Where? We'll be talking about those. Obviously, these joints are ankle and subtalar joints. And then, who is supplying their deep fibular nerve? So my common fibular nerve, it divides into superficial fibular and deep fibular. So I have common fibular, which becomes, common fibular was coming from, is a branch of sciatic nerve, is a continuation of sciatic nerve, usually given in the cubital fossa. And then it runs close to the neck of my fibula bone, and there it divides into superficial and deep. So deep fibular nerve is controlling the dorsiflexors and inverters who lives in the anterior compartment of my leg. This is the key concept. If you remember these three lines, you can answer any question which is emerging from here. You are done with the actions, you are done with the nerve supply. This is a broad picture. Then what is happening? In the posterior compartment, I have opposite action. These are plantar flexors. So they are flexing towards the planet. And they are also inverters. They are not doing something opposite to that. So they are the posterior compartment muscle, which makes the bulk of your leg a big chunk. That is, they are all plantar flexors and inverters. And who's their nerve? Their nerve is the tibial nerve. Now, coming to this lateral compartment, the muscle who are living here, they are doing something opposite to the muscle who are present in my anterior compartment and a posterior compartment. They were both of those groups, they were responsible for inversion, and these are evergers. So they evert my foot, and those one, anterior compartment, posterior compartment, they were inverting. This is everting. E means out, I means in. Inversion, eversion. We talk about these actions when we are doing foundation block. Nothing new. And who's their nerve? Who's left with? We have taken deep fibular nerve. We have taken tibial nerve. Think, guess, superficial. Excellent. You guys are smart. So we have sciatic becomes common fibular and tibial. Tibial for the posterior muscles of the thigh, posterior muscles of the leg. And the deep branch of my common fibular for the anterior group of my leg, and the superficial branch for the lateral muscles which are present in the lateral compartment of my leg. And you know their actions, you know their nerve supplies. If you know this much, you have done 50% of the leg. You are done with this. Now, let's place the things in our, so this is my summary slide. I just brought it here first. So let's recap quickly. So what they are doing, what is their nerve, what is their artery? Artery I didn't talk about, it is the anterior tibial artery. You are explained the popliteal artery when it reaches to the interosseous membrane after going through the popliteal fossa, it divides into anterior tibial and posterior tibial. Anterior tibial runs in front of the intraosseous membrane to supply the anterior group of muscles, and posterior tibial is responsible to supply posterior group of muscles. Are we good with that? So now these are the muscles. These are the names of the muscles who lives in my anterior compartment. And what were these muscles? Let's look at them. You're looking here. The tibialis anterior, extensor hallucis longus, and extensor digitorum longus. So this word hallucis is replacing pollicis. In the upper limb, we talk about pollicis for the thumb, for my first digit. And here in my foot, for the big toe, we will use the term hallucis. And the second thing, extensor digitorum was digitorum there and digitorum here for the digits. And then tibialis anterior, a muscle who lives anterior to my tibia. So these are the major muscles who are found in my anterior compartment of the leg. And their job is what? They are dorsiflexors. And who controls them? The deep fibular nerve, branched from common fibular nerve, branched from sciatic nerve, coming from sacral plexus. Are we good so far? So that's the nutshell of the anterior compartment of the leg. Now let's put these things here. So you're looking at the anterior aspect. You're looking at tibia and fibula and the bones of the foot. So now there's a nerve. We talk about this nerve. Who's that nerve? Going close to fibula. Common fibular. Going close to fibula, common fibular. And you can see that it's dividing into two branches. There is superficial. Superficial stays laterally, and deep one is coming to the anterior compartment to control the muscle who lives here. And that is the deep branch, deep fibular nerve. Are we good? Then it goes all the way down. Where? After supplying the muscle, my deep fibular nerve, it goes all the way down between my big toe and the digit next to it. It supplies sensory nerve. It supplies, if I have to check common fibular nerve, I can just roll in this area. The web space between my big toe and the digit next to it, if I feel the sensation, if I want to check deep fibular nerve is working or not working, if I have a sensation, I can say simply the sensory part, the cutaneous part of my deep fibular nerve is working. It's perfectly all right. So at least I know that nerve has some life. When I'm doing that, when I'm evaluating a case of a trauma, then I wanted to know what I have and what I have lost. So I know without asking the patient to move his leg. Maybe he has broken his leg. Maybe he has a very complex type of fracture. The bone has been shattered. But at least you can evaluate. I think the worst I have seen, there were so many, but which I never forget. Someone was visiting a party and there was a fight, and someone literally fired with AK-47. And the whole leg, this big chunk was missing in between. There was a foot brought, and there was a leg brought, and there were some soft tissue structures which were connecting. There was no bone. It was all shattered. Then we have to see, I know I was there in that team. We have to work on that. Are we saving? Can we do some salvage? Can we repair it? Or we have to amputate it? So these are the things which may happen, and I wish should not happen. So, coming back. So we talk about common fibular nerve, and we have seen it's dividing into deep and superficial. And now, who's that? Yes, anterior compartment, anterior tibial artery, a branch from my popliteal artery. Are we good with that? And then it's going all the way down to my first web space. And here, where? At this place, this artery, when it crosses, when it reaches to my foot, we change its name We call it now what? Dorsalis pedis artery. If I have to check that femoral artery is there or not there, first I will try to localize femoral artery in the femoral triangle. Okay, it's there. Second point, I can localize it in the popliteal fossa. Not easy, very difficult, because deep to it we have muscles. So difficult to get the pulsation from there. And then easily visible place, because I cannot hunt for anterior posterior tibials, but I can easily hunt for dorsalis pedis. So if I can find it, it's coming till dorsalis pedis. I need not to go into the femoral triangle. I need not to go into the popliteal fossa. I can just touch the foot of the patient on the dorsal surface at the first web space in front of the tarsals. If I found a pulse there, I can simply say dorsalis pedis is fine. If dorsalis pedis is fine, anterior tibial is fine. Popliteal is fine. Femoral is fine. External iliac is fine. Common iliac is fine. Aorta is fine. Left ventricle is fine. Right? So this is how the journey goes. And this simple pulsation tells me all. I'm connected backwards. This is the dorsalis pedis artery. Now what else? It gives a branch which goes laterally. There are something which we'll be learning in our next session. And this branch which goes laterally, we name it. It's going lateral side. So what is the name for that? Lateral dorsal artery. Why lateral? Is going laterally. Why dorsal? On the dorsum of the foot. Why artery? It's a branch from an artery. Easy. And who this should be? So you need not to memorize everything. Use this. If you use this, trust me, you are not alone. You are the best. This is my medial tarsal artery. Are we good so far? Now, they make an arch here on the dorsum of the foot. And from this arch, I get what? Digital arteries. And they are supplying to their respective areas. Are we fine? So we have talked about the nerves of the leg and nerves and arteries of the anterior compartment of the leg. Now, let's take muscles. Because this is how first layer is the bones. Then we have neurovascular bundle. And now we are bringing muscles here. So what these muscles are supplied by a defibrillator nerve, and defibrillator nerve has reached there. Now what it has to do, it has to give muscular branches. These muscular branches usually not named. I'm using a term here. These muscles are honest. What do I mean by saying that? That they are not Alibaba. So how they are honest? Because they don't deceive you. If someone is on medial side, it will stay on medial side. If someone is on lateral side, it will stay on lateral side. It's not like it starts its journey on the medial side and flip to the lateral side. From lateral, flip to the medial side. So they're not crossing. They're not flipping across. So this is a big one, which comes all the way down. And it goes under my sole of the foot. This is nothing but tibialis anterior muscle, a big one in the anterior compartment of my leg. And then you can see that it's going to the base. It has been mentioned, and its job has been already explained. Dorsiflexors, inverter of the foot. It's providing a dynamic support. We'll be talking about these supports day after tomorrow. And then someone coming down, sneaking behind, extensor hallucis longus for my big toe, going straight to the distal phalanx. That's my extensor hallucis longus. Even if you stretch, if you flex tightly on the dorsum of your foot, you can see these muscles, especially this extensor hallucis longus. And then its job is, it extends what? Big toe and dorsiflex the foot. Now, this is someone who's controlling my digits. This is a muscle of Extensor compartment. Going to the digits. You can suggest a name for this. Mashallah, you guys are smart, you know it. So this is extensor digitorum longus. When I use the term longus, oh, there must be someone called brevis. So that we have to look for, but not now. So now what it does, it's going to my digits. So it will be extending the digit, 1. Second action, dorsiflexion, right? So easy to remember. No rocket science is here. Now, I put a band, I put a strap to close. These tendons should not be slipping out, should stay where they should stay. It has a name, superior, extensor, retinaculum. You remember the wrist, the forearm? We talk about flexor retinaculum. On the dorsal side, on the extensor side, we talk about extensor retinaculum. So this is the same in the leg. So when I use the term superior, it means I will be having inferior one also. Because I need so much stabilization. It's not happening, the tendon was here and after a little bit it runs away. No, they have to stay in their place. And this we call it as inferior extensor retinaculum. Any rocket science? Now, what I've shown here, guys, this sleeve is complete. If I put the whole sleeve, your muscle will become invisible. And then when I'll post it for you, you'll cry where everything is covered. So it's just shown in a part. But don't take this message that this is covering here and not covering here. It's covering everywhere. Are we good? This is the deep fascia. So now this is the deep fascia of my leg, and it has a name to it. It's in a box. And we talk about compartment syndrome. I need not to talk again. If someone fractures his leg, has a burn, then this fascia is the boundary who controls the structures which are present in this area. Now if these muscles swells, outside this thick wrap is there, so they cannot expand outwards. Whatsoever they can expand, they will, but there is a limit to it. So now they will be causing compression on the nerve and artery. Compression on the nerve will give a pain, but compression on an artery will stop the supply. Where? Distally. I will not be able to find dorsalis pedis. I will not be able to find perfusion at my digits in my foot because my anterior tibial artery has been clasped, has been compressed. So maybe the posterior tibial. So my foot can go gangrene, turn blue and turn black. And then you're left with no other choice except for bringing an amputation. Amputation means you're chopping it away. You have seen people with their amputated hands and amputated foots. Now, let's talk about, this is what you're looking at, the same. But we have talked so far. There are 2 extra muscles, but rest is you're looking at the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and then 2 muscles from my medial, lateral. Thank you very much. And their nerve supply was superficial fibular nerve. Are we good? So this is the schematic presentation of who lives here and what they do. Now, let's summarize. Muscles are, what these muscles? There is another group of muscles who are everters. Who are they? Their nerve is superficial fibular nerve. So I'm talking about whom? A muscle who are present in the lateral compartment. Their blood supply is coming from where? Fibular artery. It's a branch from posterior tibial artery. So posterior tibial is not only supplying in the posterior compartment of the leg, but it also supplying in the lateral compartment of the leg. So my posterior tibial artery, it further divides into a fibular branch and it continues as it is. And these muscles are, it has only 2 muscles. You have seen with this blue. And these muscles are fibularis longus and fibularis brevis. Guys, you will find in your books another name, fibularis tertius. Some books write it with the name, with the muscles of the anterior compartment. Some books write it with the lateral compartment. Basically, it's a detached part of my extensor digitorum muscle. It's a very tiny muscle, and we can play with it anywhere, but it's not a major key player. We are talking about major issue. If we can go in details, then sky is the limit. To finish this lecture on the leg, I may need a month plus. But now I have to finish it in 1 hour. And we are only focused and targeted with the relevant, clinically important points, not everything. Now, let's put these muscles, what I have talked about. What muscles I have talked about? Fibularis longus and brevis. And you're looking at the lateral aspect of my leg. Why I'm saying that? Because you're looking at the fibula. Fibula is placed laterally. So let's put these muscles here. We are good with these names of the bones. Look at it. Who's this muscle? Fibularis longus. It goes all the way in the sole of my foot, and it has a long journey. It is attached at so many places. And this is the action. It everts, and it also helps in plantar flexion. And the one which is anterior to it is my fibularis brevis muscle. Are we good? Now, the nerve for these muscles, superficial fibular nerve, branch from common fibular. Excellent. So now they are kept in a strap. What name we can give to that? Superior and inferior fibular reticuli. So now we are looking at this nerve, we know about him. Common fibular nerve. Now this common fibular nerve. Ayman spent good time on this. He brought that fracture and all that. So if you see a fracture at the neck of the fibula, always suspect injury to common fibular, superficial or deep branches of it. And then you can find out foot drop and other things, loss of sensations. So you're looking at defibular nerve, which is the nerve for my anterior compartment. And the superficial fibular is controlling these lateral muscles. And you can see it goes all the way between my first and second toes. We don't call them digits, we call them toes. Digits are here. Are we good? So now, you're looking at the superficial. After supplying this muscle, it's been visible to you. Can you see it? Okay. So now, posterior compartment. Who lives in the posterior compartment? First, look at their summary. These muscles their main job is plantar flexion, and they are also inverters. Now, they plantar flex the foot, where? At the ankle joint. And they invert the foot at subtalar joint. So we have ankle joint is not one. So we need to understand what is this subtalar and what is this ankle. And then their nerve is tibial nerve. Their artery is posterior tibial artery. We talked about that. I don't think I need to go back for that concept. And now these muscles are arranged in layers, like my forearm muscles. Guys, it reminds me one question, which was brought as an appeal question during your midterm exam. The question which was asking where we can find the pulse of ulnar artery, and somebody just took a snapshot. When I teach you in layers, so I should take separate layers to make you understand. These layers are for your understanding, but actually if you look at it in your own hand, it's not in layers, it's the one complete forearm. So if you're bringing an evidence of first layer, you have to see the second layer, you have to see the third layer. I wrote in my reply, you should see the complete picture. So evidence should be when everything is placed where, and this is where you learn it when you'll visit the labs. You'll see on cadavers. You'll see the final picture. Then you can say this artery is medial to which tendon and lateral to which tendon. But if you take first layer, and then it will be on the basis of first layer. The question was not asking you that this ulnar artery is placed in first layer, medial and lateral to which tendons? The question was inquiring in the wrist, in a complete hand. So when you are, I know this happens. We are prone to make mistakes. But when you are reading questions, I saw today the questions were easy. Anatomy questions were not difficult. But people were struggling. I didn't have enough time, so I didn't talk much about those. But when I saw how people were behaving, some of the questions people were messing around, and I was surprised. And I don't know why people were struggling with the concept of Tendelberg sign. Even I uploaded a presentation only on this Tendelberg sign. It was visible on your Moodle. But guys, if you don't open your Moodle, if you don't listen to that, then tell me how I can help you. I think yesterday night I was done around 12:30. It was there. Anyways, so the first layer, the muscles are, first muscle, gastrocnemius. And then we have a middle layer. So first layer was having one muscle. Second layer has one or two muscles. And these muscles are soleus and plantaris. Now this plantaris, it may be absent. It's a very tiny muscle. And then the third layer, which is a deep layer, it has three muscles. And these muscles are flexor for my big toe, flexor for my digit, and a counterpart of tibialis anterior. This is how I learn things. I don't memorize anything. I only learn pictures. If I know a picture, I can explain it all. I can write the answer. If I don't know the picture, I cannot. I cannot memorize. How much you will memorize? So now, these are three so-called dishonest muscles. Let's see how they are dishonest. Now, we are looking at the leg from the posterior side. Now, superficial layer, gastrocnemius. And then this muscle becomes a tendon. This tendon is going to one of the biggest bone of my foot, calcaneus. And we call it tendocalcaneus. Do you know the story behind this tendocalcaneus? It's a Greek myth. Yeah, Achilles, yes. What was that Achilles story? No, what happened? He was a Greek god. His mom, this is all khurafat. His mom dipped him in a water, and which they presume it's a holy water. And the place from where the mom was holding was this tendon. So he was dipped in that water. But that part, as it was in the pinch of the mom, so that part was not covered. So any other place where he was shot, that was not causing any damage to him. And his cause of death was he was hit at that place which was not covered with that holy water. I don't believe in that, but anyway, this is a story for good fiction. So on that basis, we call it also tendoachilles. But I use it for learning this. Rest is fine. So this is my gastrocnemius, and it becomes a tendon. Guys, this tendon is very strong. And trust me, in old days, people robbed the travelers because there was no civilization. In deserts, people were going on camels and other things, horses. They robbed their whole group of people who were traveling. They snatch money, everything, and then they cut this tendocalcaneus. Now, if you cut tendocalcaneus, person can never walk. You want to give someone a death which doesn't come in a minute, and you want someone die of hunger and starvation, don't do it. Cut tendocalcaneus. Now this person can never walk. Leave him in a desert. He cannot run away. He cannot go away. This torture has been used so many, in different wars and different situations. A very common place which was being damaged and cut and all that. Anyways, so this is it has a lateral head and a medial head. Gastrocnemius. And then tendocalcaneus, yes, we tap it here. To check what? Now I'm sure you can answer me. The integrity of the nerve, who's controlling this muscle? What is the nerve? Tibial. Excellent. Now, if you learn the segment, spinal segment of the tibial nerve, you can simply say that we are checking the reflexes where of this segment, tibial nerve. You tap it here, you can see the contraction building up in this muscle. Now, it does plantar flexion. And as it crosses my knee joint, so it's also helping there a little bit. Now, just medial to it, someone else has come. Who's that someone else? Can you see this gray line? So who's that someone else? That is my plantaris tendon. Some people say it is blended with endocalcaneus. Some people say it goes separately. It's a very point of prestige for some people. So if somebody asks you like that, say it goes separate. Otherwise, it can be blended. It's okay. But it's not a rocket science. Don't spend time on that. Now, this is the belly. And now here I have small saphenous vein. Location of the small saphenous vein. This is the popliteal fossa. You can see that my gastrocnemius is two heads, and on top I have laterally the bicep femoris, medially semimembranosus and tendinosus, and they are giving a diamond-shaped space. That we learn it as the popliteal fossa. Look at its contents. You can figure out yourself. Popliteal artery, tibial nerve. If you stretch more, you can find common fibular and all that. Right? Now, coming back. We have chopped the gastrocnemius muscle to show what is inside. So we have covered the first layer. Now there is a soleus, the big one. Dr. Ayman was talking about it's like a fish. Is it really fish? Yeah, it looks like that. So this is my soleus muscle. And then it also blends with this tendocles. And it does the same job. Popliteus muscle, you can see this. This is the important muscle, we talk about it. It helps in what? Unlocking the knee which is locked, which is screwed in. So it rotates it. First it brings the rotation, then you can flex your knee, which is an extended format. Are we good so far? Plantaris, where are you? Look at him. Are we good? So now, these all were honest. Arteries we talk about, popliteal artery, posterior side, posterior tibial artery. And then it gives genicular branches. Guys, don't forget learning anastomosis around knee as well. I remember a few years back, this was one of the questions in final SAQ. Name the arteries contributing around anastomosis, which has been around the knee joint, and people wrote only superior, middle, and inferior. And I remember the marks were 4, and people were getting 1 out of 4 because they think only these are the 3 branches. There were so many. So please, we give marks according to our key. If you don't put a name, you will not get a mark for that. So these are few of the names, not all of them. Then we have the popliteal vein, and you can see now the tibial nerve is coming up. Who's that? Common fibular nerve. Then, now this tendon can rupture, and then it causes disasters. You need to read about rupture of the tendon of tendocles. Now guys, deep layer. What we have in the deep layer? We talk about 3 muscles. Let's put them. Look at him. He was coming all the way and then it twisted. It's going to my digits. It's called flexor digitorum longus. Then I have tibialis posterior. Look at him. Right? It goes all the way. And then I have flexor hallucis longus. It was all the way on the lateral side and it moved to the medial side. So if I track from the medial side, I will be expecting upwards, but it's coming all the way in a different direction. So there's a big crossover at this place. So tendons are changing their position. That's why, in a fun we call it dishonest group of muscle. This is not a clinical term. Don't use it. So arteries and nerves, we are good with posterior tibial artery. Popliteal becomes posterior tibial. Then it gives, what was that? Excellent, you guys are smart, mashallah. Anterior tibial. And then you can see the posterior tibial giving another branch which runs laterally. We call it femoral, fibular branch. Fibular artery which supplies my lateral compartment group of muscles. Tibial nerve, you can see it's dividing. Common fibular nerve. Any issue so far? So they divide, give digital branches, and they supply there. There's a reticuli, flexor, because these are the flexor muscle. This is the place. A mnemonic to remember them, relationship. I found this mnemonic is more difficult. You can remember it simply. Now, this is how these muscles were attached. Schematic version. You're looking at the popliteus. You're looking at the flexor, hallucis, digitorum, tibialis posterior. All of them are visible to you. Now, this is the description of the veins. And now, this is a very conceptual thing. I like you to be focused now. Fine. This is a situation of my leg. We have an artery. And this artery is posterior tibial artery. Right? Dr. Sadia was talking all the time. Vena committens. So these are the vena committens of my tibial artery. I want to be more precise. I will say posterior tibial artery. Any rocket science here? Anything new? Now, they are enclosed in a fascial sheet. We talk about these sheets in axilla, in femoral region, in adductor canal, everywhere. So this is a connective tissue sheet which encloses the arteries and veins. They are in a sleeve. They are together. And they are sandwiched between the muscles. Are we good so far? Now, what happens? And these muscles and arteries and veins and nerves, they are in deep fascia. Yes or no? Yes. So now, these are what? This yellow thing is my fatty layer, and outside this, in the superficial fascia, I have superficial veins. Are we good? So you're looking at the superficial veins, and you have seen the deep veins are accompanied the artery, but the superficial veins are on the surface. Yeah, it's not great saphenous, it's those who are going to the great saphenous. Great saphenous is the big one. So these are the veins. We have so many, and they don't have a name. So these are called superficial veins. Superficial veins are connected to the deep veins through these channels. These channels are called perforators. Guys, this is a very important concept, and if you stay focused now, then you will understand everything. If not, then I'm sorry. And we all know veins, the big veins are provided with valves. So they allow one-way direction. You know, my heart pumps blood, it reaches your capillary level. Who bring this blood back to my heart? From my foot, from my leg. That I'm trying to explain here. So veins have valves. Blood can only go in one direction. It cannot come back. If it's push, it will stay. Then it's push, it will stay. So now, so superficial veins are connected with deep veins. And then look at the valves which has been shown in these deep veins. Can you see them? So they are only there to allow one-way direction. Thank you. So now what happens? And there are valves which are also connecting my superficial vein to deep veins, and each perforator has these valves, and there is only one-way flow is allowed. This is normal resting position. Now look at it. What happened? My superficial vein also have valves. So my superficial vein have valves, my deep vein has valves, and the veins who are connecting superficial to deep, they have valves. And now everything is under the skin. Now this is the situation. I'm exposing it a bit. Now my heart is pumping, so blood is coming, so artery is pulsating. As a result, what happens? The veins who are on the side, they will be compressed. The veins who are vena comitans, they will be compressed. So this compression, this pulsation of the artery, it will be pushing blood upward. So it will become a force, which will be pushing the blood whatsoever has reached to these deep veins, vena comitans. So when I'm moving, what time my arteries are more expanding? What time I'll have when I'm doing some workouts, when I'm running, when I'm doing some activity, my muscles are contracting. So now arteries are responding to bring this contraction. So as a result, look at the muscles. They all are in a sleeve. Now these muscles, they are in a contracting phase. Arteries inside, pulsating. The muscle outside, they are contracting. So now the veins has been squeezed. So this squeezed, internally created by this artery and externally created by the skeletal muscle. The veins has been sandwiched, pushed in between. So now when you push something, the blood will force to go upwards. There are valves, so they don't allow this blood to fall down. Are we good? Now what happens? So blood is being forced to go upwards through these vena comitants. Now, what happens? Leg conditions. We talk about this. We talk about this, not really. These are the sequences. These are the problems. These are the solutions. Think. Problems. Think problems. Now, so now, these veins, when they are pushing, the blood will return back. And this blood, when the valves become incompetent, so now blood will be forced to stay in these veins, and that will cause a problem. I think we have time. One of my slide is found missing. Let me insert that. Stay connected. In the meantime, if you have any question, Mice, can you help me? If they have any question? Ask.
Yeah, okay, so my first question, with regards to the tibia bone, in clinical practice, with respect to clinical practice and bone marrow biopsy, do physicians utilize that bone to do a bone marrow biopsy rather than the iliac bone, especially with kids?
Gentlemen, there are various preferences regarding the different sites and what they are preferring. The bones which are subcutaneous, which by saying subcutaneous means easily accessible. So easily accessible bones are major hunt. Make sense? So easily accessible bones are major hunt, and they approach for bone marrow biopsies, they approach in the sternum, they approach to the iliac crest. So there are various locations, and then it goes with the unit policies, with other things to look for like what is more appropriate, and every person has his own learning curve. So there is no rocket science, there is no hard and fast that this is the only thing which can be taken as.
My second question,
Mm-hmm.
so the superior extensor reticulum, is there a common disease like carpal tunnel syndrome that occurs in the superior extensor reticulum with the superficial perineal nerve?
Usually this carpal tunnel, we talk more with the upper limb.
Yes.
That is seen more there. And usually it's not reported in that area. No problem. Any other thing? In the meantime, I'm hunting the slide of my the slide which was missing. Yes.
Doctor, someone was asking if during a calf pump, does the blood in the vein get stuck in the bottom?
During what?
A calf pump?
I didn't get it. Say it again.
So they're saying if during a calf pump,
Mm-hmm.
the blood in the veins get stuck in the bottom.
Mm-hmm. I think, give me a second so I can take this picture and this picture, Control C. I'm fine with that. Where is my existing one? Control V. So we were here. Let's go back. I'll be answering this question, but this concept which I was talking about, it was really important. So I like to stay focused on what happens because the what happened part was missing. So guys, we are set with that. We talk about this. I'll be going a little bit backwards. We talk about this. There is a contraction. All that is happening. Now, the blood is, with this action, blood is going upwards. And now in this situation, my superficial veins, so it's going upwards. So my superficial veins are connected to the deep veins, vena comitans. So they are pouring blood inwards. So my whole body blood is being sent upwards to reach to my right atrium of the heart. Are we good? Now what happens? People have problem with these valves. Can you see that these valves disappear? And these are called perforators. So the valve disappear. Now what happened? The new situation. Now when there is a contraction, vena comitants are compressed. So they have been squeezed. So they are sending blood outwards. Rather than sending upwards, the blood starts coming outwards. Where? Towards the superficial veins. So the blood which has reached to my deep veins is being now pushed outwards. As a result of that, too much blood is coming. And this too much blood, my superficial veins becomes dilated. They becomes dilated. And that's a problem. And this dilatation of my superficial vein, and with each contraction, the blood is being poured in the superficial veins. And this dilatation, we call it varicose veins. In Arabic, you call it Dawali. And that is the one which you can see here. So this person is suffering from, now his superficial veins have been dilated. And this is called varicose veins. Right? And this thing, there's no tab. Even surgery is not the answer. These are numerous perforators. It's not one or two. How many you'll take? How many you'll do this and that? And this is what happens. This is the mechanism of this. And if it stays untreated, these are the ulcers. These are foul smelling. You cannot withstand with these people. This is the treatment. Anti-embolic stockings. After major surgeries, patients were asked to wear these stockings. Then another condition, deep venous thrombosis. You remember when you are sitting in a long flight, your advice, keep moving your legs, get out of your seat, move around. And there are so many other conditions. People develop deep venous thrombosis, and this is disastrous sometimes. And then this is elephantiasis. There is a special type of fly which is found in deserts. They bite people, and their legs will go like an elephant leg. Are we good so far? So this is the summary of the muscle which we talk about. Thank you very much. Now can you turn on the lights, gentlemen? So I should stop recording.